Assalamu alaikum. We'll discuss pelvic organ prolapse, which is a very interesting subject in gynecology. What is the definition of pelvic organ prolapse? Pelvic organ prolapse can be defined as a sense of pelvic organs such as the urinary bladder, rectum, vagina, uterus, below their normal anatomical position due to distortion of their dynamic and integrated support. What are the symptoms of pelvic organ prolapse? Pelvic organ prolapse can cause symptoms directly due to the prolapsed organ or indirectly due to organ dysfunction secondary to displacement from the anatomical position. We start with the direct pelvic organ prolapse symptoms, including direct symptoms include a sensation of vaginal bulge, heaviness or a visible protrusion at or beyond the introitus, lower abdominal or back pain, or a dragging discomfort relieved by lying down or sitting. So these three direct symptoms of pelvic organ prolapse. The indirect symptoms will depend on which other organ are involved in the prolapse. They include difficulty in urination or defecation, what's called obstructive defecation, sensation of incomplete emptying of the bladder or rectum. Patient may have to support or reduce the prolapse with her fingers to be able to avoid or evacuate stool completely. A movement called digitation. Urinary or fecal incontinence may be also present. Sexual dysfunction due to introital laxity. Bleeding from abrasion of the prolapsed part. So, we have three direct complaints or symptoms of POP and 6 indirect complaints or symptoms. What are the etiology of pelvic organ prolapse? The risk factors predisposing to the pelvic organ prolapse are either congenital, weakness of the mesenchyme, or due to obstetric trauma. The obstetric trauma causes pudendal nerve damage with increased nerve conduction times, delayed nerve conduction, thinning or avulsion of pubic muscle from its insertion on the pubic ramus on one or both sides. This obstetric trauma is usually caused by prolonged impaction of fetal head deeply in the pelvis, compressing the pudendal nerve during its transfer from one sciatic notch to another around the base of the ischial spine. So the nerve and vessels, pudendal nerve and vessels, are compressed on one side or both sides against the bone of the base of the ischial spine, giving rise to damage of the pudendal nerve. As a result of prolonged second stage of labor or prolonged impaction of the fetal head in the second stage in mal-conducted labor is the thinning or avulsion of the pubic talus muscle from its insertion on the pubic ramus on one side or on both sides. This thinning and weakness of the muscle may be due to prolonged compression of the muscle fibers, or due to ischemia, or due to affection of the nervous supply of this muscle. So, to conclude, pelvic organ prolapse is either congenital weakness or commonly due to obstetric trauma, summarized in one sentence: badly conducted labor. Badly conducted labor. This algorithm summarizes the pathophysiology of prolapse. Here we have congenital weakness or trauma, obstetric trauma. One of them, when subjected to increased intra-abdominal pressure, lead to prolapse. So, congenital weakness or obstetric trauma are the predisposing factors, the precipitating factor, predisposing factors, and the precipitating factor is the increased intra-abdominal pressure, and the end result is the pelvic organ prolapse. There is a gap between the fibers of the pubic talus on each side to allow the passage of the urethra anteriorly, vagina and rectum in sequence from anterior to posterior, called the urogenital hiatus. The levator muscle support the pelvic organs and prevent excessive loading of the ligaments and fascia. For the support of the vagina and related organs as the urinary bladder, urethra, and the rectum, Delancey described 3 levels of support. They are all provided by fascia at 3 levels of the vagina: the apex, the mid vagina, and the lower vagina. Level 1 support is provided by the uterosacral ligaments suspending the back of the uterine cervix and the vault of the vagina to the middle 3 pieces of the sacrum on either sides. So we have 2 uterosacral ligaments, right and left uterosacral ligaments, which are attaching the back of the cervix and the vault of the vagina to the puny sacrum. And this is what's called level 1 support. To get down to the mid vagina is supported by the fascia lying between the vagina and the bladder anteriorly, what's called vesicovaginal septum or sheet of fascia. or between the vagina and rectum posteriorly, and it's called the rectovaginal septum or sheet of fascia. These fascia, anterior and posterior, fuses laterally and runs to attach on the pelvic side wall. The level 3 support, which supports the lower vagina and related viscera, is the perineal body, which has the posterior vaginal fascia fused to its upper surface. So we have the fascial support of the vagina divided by Delancey into 3 levels of support. Level 1, provided by the heterosacral ligament, and it supports the vaginal apex, the vault of the vagina, posteriorly, and the back of the uterine uterine cervix. The level 2 support, which support the mid vagina, is provided by 2 sheets or 2 septa of strong endopelvic fascia. Anteriorly, the vesicovaginal septum, and posteriorly, the rectovaginal septum or rectovaginal sheet of fascia. Both these septa fuse laterally to the pelvic side walls. And lastly, the lower vagina is supported by the strong wedge-like connective tissue, which called the perineal body, situated in the center of the perineum, and its upper end fuses, or its upper surface fuses with the posterior vaginal fascia. Development of prolapse, pathogenesis of prolapse. The pelvic floor and ligament work together to provide support against increased intra-abdominal pressure. Prolapse is almost invariably associated with perineal body damage. Causing an enlarged vaginal opening. Prolapse can then occur if the apical support is lost, or if or if the pelvic floor muscles are ineffective, or directly as the result of perineal body deficiency. Often a combination of factors is existing. To summarize, the levator ani muscles, puborectalis, pubococcygeus, and iliococcygeus, support the pelvic organs and relieve excessive pressure from the ligaments and fascia. The heterosacral ligaments provide essential apical support of the vagina, of the vaginal apex. Vaginal fascia support the mid vagina. the perineal body is very important in supporting the lower vagina. All structures provide a dynamic and integrated support of the pelvic fascia. We come to the support of the uterus itself. The endopelvic fascia becomes more condensed and specialized as ligaments at certain parts to support the uterus. Namely, they are condensed to form the transverse or cardinal ligaments or McEnroe's ligaments on both sides, supporting the side part of the supravaginal portion of the cervix and lower uterus. That's called the cardinal ligament, which is the most of the strongest ligament supporting the uterus. Anteriorly, they are condensed to form the pubocervical ligament, and posteriorly the uterosacral ligaments. So, at a higher level in the pelvis, the endopelvic fascia is condensed and becomes more specialized to form ligaments, fascial ligaments. We have three pairs of ligaments supporting the uterus in the center of the pelvis, attaching it to the side walls of the pelvis. These ligaments are in the middle, supporting to the side walls of the pelvis, the uterus to the side walls of the pelvis, and attached to the supravaginal portion of the cervix and lower uterus are the cardinal ligaments or transverse cervical ligaments or McEnroe's ligament. They are all name of the same thing. Anteriorly, the pubocervical ligament attaching the anterior aspect of the cervix to the back of the pubic rami, and posteriorly the uterosacral ligament supporting the back of the uterine cervix, supravaginal portion of the uterine cervix, and the vault of the vagina to the middle three pieces of the sacrum. We used to divide the pelvis into anterior compartments, posterior compartments, and middle compartments in relation to the supportive elements. This is the anterior compartment, this is the middle compartment, and this is the posterior compartment. How to assess a case of prolapse? We start with history taking. You should elicit the presenting symptoms and severity of these symptoms and include questions to ascertain if the patient has any coexisting urinary or fecal or sexual problems. On the other hand, one should be sensitive to the emotional aspect of the problem, but specific questions should be asked about sexual discomfort and difficulty in achieving orgasm. This is important for maintenance of a good quality of life. We come to clinical examination. Clinical examination should be ideally done in the lithotomy position with a Sims speculum. This allows retraction of the anterior and posterior vaginal wall in turn to allow full assessment of the degree of prolapse and to assess how much descent of the cervix and uterus is present. Prolapse is classically described in 3 stages of descent, and note should be made of whether it occurs at the patient straining or at rest, and whether traction has been applied or not. This is the Sims speculum, two-bladed Sims speculum, and this is a Sims speculum inserted, and the patient is in the exaggerated left lateral position, what's called Sims position, and the physician, examining physician, standing behind the patient, facing her back, and insert one blade of the Sims speculum in the vagina in this position, and exert tract to retract the posterior vaginal wall to the level that the anterior vaginal wall is more obvious and can be seen easily. This is what's called Sims speculum examination in a Sims position. These are some instances of prolapse. This is the uterus, and this is the vagina. The base of the bladder is related to the anterior vaginal wall. When there is a defect or weakness in the vesicovaginal septum, the high pressure organ protrudes or prolapses into the lower pressure organ. Here, the higher pressure organ is the bladder. Base protrudes through the weakened vaginal septum, the vaginal fascia, into the anterior vaginal wall, causing a prolapse of the bladder base into the anterior vaginal wall, what's called cystocele. Cystocele. Lower down in this picture, the urethra, which is a high pressure viscous, protrudes through the lower part of the anterior vaginal wall, causing what's called urethrocoele. On the posterior aspect of the vagina, the rectum protrudes through the posterior vaginal wall, causing erectocele. In the last picture, the anterior vaginal wall is intact, the posterior vaginal wall is intact. However, the vault of the vagina or the vaginal apex is weakened due to diversion or separation or weakness of the two uterosacral ligaments, causing a gap in between the two ligaments through which the intestine with its peritoneal covering protrudes through the posterior fornix of the vagina, causing what's called enterocele. This is the enterocele. We go to another example. This is a photo of a patient with this Sims speculum inserted. The patient is in the lithotomy position, and the blade of the Sims speculum is inserted in the vagina, and the patient is asked to strain this cystic bulge is seen on the anterior vaginal wall. This is what's called cystocele. This is the portio vaginalis of the uterine cervix protruding through the vagina and outside the hymenal ring. And this is a second degree uterine descent. This third picture is the posterior vaginal wall mass. However, the perineum is intact, the perineal body is intact here, and this is erectocele without deficient perineum. This patient have erectocele and deficient perineum. A third example to facilitate understanding. This is a post-hysterectomy vault prolapse. This patient have had total abdominal hysterectomy, and some years later she had a chronic chest problem followed by increasing intra-abdominal pressure, and the vagina is inverted inside out. This is what's called post-hysterectomy vault prolapse. This is the patient on the office and this patient on operative theater for surgical repair. In view of the complex relationship between the prolapse and bladder and or bowel function, if women have additional indirect symptoms, then it is a must to arrange urodynamic assessment or functional test of the lower bowel, which may include the following. These tests should be ideally performed before surgical repair of a case of pelvic organ prolapse with indirect symptoms related to the urinary bladder or the rectum. First, the endoanal ultrasound to check for anal sphincter defects. Second, rectal manometry for evaluation of the continence, rectal continence or fecal continence. Flexible sigmoidoscopy to search for lower GIT abnormalities that may be exaggerated after or interfering with the surgical repair. Defecating proctogram. Ideally, such patient should be reviewed with the completed investigation in multidisciplinary team meeting including gynecologist, colorectal surgeon, continence nurse, and physiotherapist. This is the ideal management for cases of prolapse or ideal evaluation for the management of a case of prolapse. Stages of prolapse, there is a dilemma of staging of prolapse. We have used in the past years for many classifications of prolapse. And all these prolapse are substituted since 2011 by the most recent and most objective classification of prolapse, which is called POPQ or pelvic organ prolapse quantification. However, to simplify staging of prolapse, we should know that prolapse is divided into 3 stages. The first stage, where the prolapse does not reach the hymenal ring or the hymen. Second stage, where the prolapse reaches the hymen but not exceeding the hymen. The third stage, when the prolapse is mostly or wholly outside the hymen. This condition is called procedentia. Procedentia. Vaginal prolapse is formally staged using different methods, as we said before, but the most important assessment is whether the vaginal prolapse reaches to or beyond the hymen. Finally, it is important to assess whether the perineal body is intact or has become attenuated, resulting in enlargement of the vaginal opening. These are examples of the old classification methods. This is a normal situation. This is the first stage. Both are the second stage, and this is the complete procedentia. This is the recent POP-Q complex staging of prolapse. We the base line here is the hymenal ring. All the types of prolapse above are calculated in centimeters, negative centimeters. When they protrude through the hymenal ring are positive centimeters, and so this is the most accurate method of staging prolapse, and using or measuring the prolapse with centimeter, whether above or below the hymenal ring. According to the POP-Q stages, stage 1, most distal portion of the prolapse is more than 1 centimeter above the hymen. Stage 2, the most distal part of prolapse is less than 1 centimeter, proximal or distal to the hymenal ring. Stage 3, the most distal portion of prolapse protrudes more than 1 centimeter below the hymen, but not further than 2 centimeters less than the total vaginal length. Stage 4, complete vaginal eversion is essential. For more detailed explanation of POP-Q, you may refer to my slideshow on the slide share under the name of Osama Warda, POP-Q evaluation. We come to the management or treatment of prolapse. Treatment of prolapse is divided into 3 main types of treatment. The first and most important is the preventive measures. Preventive measures. Prevention is always better than cure. Prevention here consists of good attendance of labor to prevent prolonged second stage, to prevent obstructed labor, to prevent mismanagement of instrumental delivery, to avoid injury to the pudendal nerve or the puborectalis muscle, or disruption of the perineal body. The second method for treatment is the conservative treatment, including pelvic floor exercise following delivery and the use of supportive vaginal pessaries. For women with urinary or bowel symptoms, conservative treatment for these symptoms can be commenced at the same time for the prolapse. Pelvic floor exercises. A course of supervised pelvic floor exercises will reduce the symptoms of prolapse, and for women who are keen to avoid surgical treatments, this can be an effective first step, although there is less evidence that pelvic floor exercise will reduce the anatomical extent of prolapse, and it is unlikely to be helpful for women whose prolapse is beyond the vaginal introit. So, to summarize, pelvic floor exercise usually improve symptoms but did not improve the anatomical prolapse. Ring pessary are usually tried first, and the most commonly used are the ring pessaries. but an intact perineal body is necessary for these to be retained in situ. Self pessaries, Gellhorn pessaries, and other are useful for women with deficient perineal bodies. So, the contraindication for use of ring pessary in pessary requiring patient is deficient perineal body. In this patient, we use self pessaries or Gellhorn pessaries. It is usual practice to replace the pessary every 6 months and to examine the patient for signs of vaginal ulceration, especially the elderly. Although this frequency is traditional and not based on evidence. We may change it every 3 months. There is no solid evidence for the 6 month duration. The indications of pessary are three. First, if the patient is unfit for surgery. Second, if the patient refuses surgery. The third is during pregnancy. Pessary is the only management to relieve symptoms during pregnancy and early period. Because pregnancy is a contraindication for surgical management of prolapse. We come to the complications of pessary. These complications are uncommon and usually minor, including bleeding, discharge, although rarely the pessary can become incarcerated and cannot be removed easily except under anesthesia. And in rare cases, it may cause rectovaginal or vesicovaginal fistulas when it is neglected for a long period in badly cared elderly in shelter homes. Sexual intercourse remains theoretically possible with a well-placed ring pessary, but not with the other types of pessaries. So, would not generally be suitable for women who are sexually active. Motivated patients can be taught to insert and remove their own pessaries if they do wish to remain sexually active. She removes her pessary before the sexual intercourse and reinsert the pessary after the end of the sexual intercourse. We come to the surgical management for prolapse. Surgical treatment for prolapse is common and the most efficient method of treatment in most of cases and can be offered if conservative treatments have failed or if the patient chooses surgery from the outset. There are a wide range of specific procedures. The procedures chosen depend on which compartment is affected. If it is anterior compartment, middle compartment, or posterior compartment to facilitate. The anterior compartment deficit results in urethrocoel and cystocele. The middle compartment deficit results in uterine prolapse. The posterior compartment deficit results in enterocele, rectocele, or vault prolapse. The second determining factor for choosing the surgical procedure for management of POP, whether the woman wishes to retain her fertility or not. For example, If a patient 35 years old and has a cystocele and has a second degree uterine descent, and she had one living child, so she want to preserve or retain her fertility. This patient is suitable to perform a Fothergill operation. This Fothergill operation or Manchester operation constitutes anterior repair of the cystocele, which is called the anterior colporrhaphy, posterior repair of the rectocele, which is called posterior colporrhaphy, and if the perineal body is weak, we perform additional perineorrhaphy, and if there is supravaginal elongation of the cervix, we amputate the excess cervical length, and so we had anterior colporrhaphy, posterior colporrhaphy, and amputation of the cervix. These are a complex procedure called Fothergill operation. If there is anterior compartment defect, let's say there is a urethrocytocele or cystocele only, the patient had anterior colporrhaphy. If posteriorly rectocele exists only, posterior colpopeneuraphy. Okay? If this patient had completed her family and does not want to retain her fertility, his vaginal hysterectomy is done first and repair of the pelvic floor followed. So we have many procedures, either anterior colporrhaphy or posterior colpopeneuraphy, or both, what's called classical repair, or we had to perform Fothergill operation in second stage prolapse in a patient wishes to retain her fertility, or vaginal hysterectomy and repair of the pelvic floor if this patient had no further wishes to retain her fertility. Usually, we prefer the vaginal route for surgery in cases of prolapse. Abdominal techniques are described in the literature, but are less commonly used for surgical management of prolapse, pelvic organ prolapse. The essential principles for prolapse are summarized later on. Prolapse surgery is performed through the vagina to restore the ligamentous tissue support to the apex, anterior and posterior vagina, anterior repair, posterior repair, and the repair of the perineal body, as we mentioned before, perineorrhaphy, anterior colporrhaphy, posterior colporrhaphy, or post classical repair. The vaginal route can also be used for the post-hysterectomy vault prolapse, attaching the vaginal vault to the right sacrospinous ligament with non-absorbable or slowly absorbable suture. But there is an abdominal approach to perform sacrocolpopexy, either by open laparotomy or laparoscopically, preferably laparoscopically. It is an option that will provide excellent, durable, long-term cure. However, this excellent procedure had a common side effect, which is constant back pain. Constant back pain that should be, we should research and extend our research to find substitute with the same efficacy but without this annoying complication, which is a back pain due to fixation of the vaginal apex to the periosteum of the sacral promontory. In the last 3 to 5 years, there has been an increasing number of women wishing to avoid hysterectomy during prolapse surgery. So, both sacrospinous fixation and sacrocolpopexy can be performed by attaching a mesh to or a suture to the cervix rather than the vaginal vault in the presence of the uterus. Vaginal repair using mesh improves the anatomical outcome and reduces the risk of recurrent prolapse. No difference in symptoms relief between standard repair and mesh repair. However, mesh repair carries the risk of the later erosion through tissues and need for removal, which is a challenging surgery, very difficult surgery to remove a mesh after mesh repair for prolapse. This table summarizes the procedure used for prolapse, as we mentioned before. Anterior vaginal repair, anterior colporrhaphy. For anterior vaginal prolapse, cystocele, not for stress incontinence. The brief description of the procedure: suture to reinforce the fascia between the vagina and bladder. Possible complication are bladder injury, and this procedure had a high recurrence rate. Posterior repair for posterior vaginal prolapse can improve obstructive defecation, and risk of rectal recurrence is low because we reinforce the support by approximation of both puborectalis, unlike the anterior repair. So repair of the anterior defect or anterior colporrhaphy, the recurrence rate is higher than the posterior colpoperineorrhaphy. Risk of rectal injury is a complication or over-tightening of over-narrowing of the vagina that may cause dyspareunia. This results from over-tightening of the puborectalis. Vaginal repair with polypropylene mesh, usually reserved for recurrent cases. Surgical repair reinforce the support with a mesh, very low recurrence rate and excellent anatomical results. However, there is a complication, mesh erosion in about 5% of cases. Mesh erosion through the bladder or rectum, which causes a fistula, a foreign body fistula, in less than 5% of cases. Dyspareunia is more common than natural tissue repair. Chronic pelvic pain may result from the presence of mesh. Excision of the mesh is difficult. So I do not prefer mesh repair for these side effects or for these serious complications. To summarize the principles of POP surgery: remove or reduce the vaginal bulge, restore the ligament tissue support of the apex, anterior and posterior vaginal wall, replace associated organs, bladder or rectum or intestine and enterocoel in their correct position, retain sufficient vaginal length and width to allow sexual intercourse, restore the perineal body for more support, because it is the most important, if I can say, it is the most important supportive element for genital prolapse. Correct or prevent urinary incontinence by repairing of the bladder neck or by adding additional procedure. Correct or prevent fecal incontinence by rectification of the rectal pathway and reinforcement of the puborectalis. Correct obstructive defecation by good support and reduction of the rectocele to its size. In conclusion, we can say uterovaginal prolapse causes troublesome symptoms, but it is not a life-threatening condition. A course of pelvic floor exercises can reduce symptoms and may reduce prolapse progression in women with mild, moderate prolapse. Vaginal pessaries are a useful conservative treatment, but do not suit all women, especially the sexually active women. Surgery for prolapse is effective, but has a recurrence rate of about 5% of cases, differing from technique to another. It is essential to perform hysterectomy for prolapse? No, it is not essential. Hysterectomy is not an obligatory step in surgeries for repairing prolapse. It is an optional procedure. The patient has the whole right to preserve her uterus and repair her pelvic organ prolapse. Mesh requires special skill. However, mesh repair for prolapse gives a better anatomical cure, but there is no convincing evidence that symptoms relief is different from standard surgery using native tissues for repair. Mesh complications are common and can be extremely difficult to manage. We have reached to the end of pelvic organ prolapse lecture. Wishing all the best of luck, with greetings from the urogynecology unit in obstetrics and gynecology department, Mansoura University Hospital. Thank you very much.